afternoon, everyone, and welcome back to the last session of day one of the Division of Mental Health and Addiction INARMS Symposium. For our last session for today, we have the CareSource team and the Jasper County Jail teams presenting on community reentry. Before we get to their informative presentation, a word on our sponsors. We are proud to have many partners in change this year. And in this session, we'll be highlighting Via Vista Health System, Groups Recovered Together, and the Great Lakes Health and Human Services Region 5 Prevention Technology Transfer Center Network. Via Vista Health System is proud to sponsor this year's INARMS as a partner in change. Since 1983, Via Vista Health System, located in Greenwood, Indiana, has been providing high-quality behavioral health care to the community. Via Vista offers care for a broad range of psychiatric and addiction disorders, services including providing care to adults, children, and adolescents. Via Vista also provides residential treatment programs for girls ages 12 through 18 and has an outpatient recovery center. Via Vista Health System, thank you for your sponsorship of Partners in Change. Groups Recovered Together is delighted to sponsor the first virtual INARMS. Groups Recovered Together is an opiate treatment program utilizing weekly small group meetings of 10 to 15 people. Groups meet for 1 hour and are led by a licensed counselor. A physician joins each group once a month and can help with questions about medication and developing a tapering plan. During COVID-19, Groups Recovered Together has been heavily utilizing telehealth, and thus we are glad to have Groups Recovered Together sponsor the first ever virtual INARMS. And Great Lakes Health Human Services Region 5 celebrates Recovery Month in Indiana with a sponsorship of INARMS as Partner in Change. The Prevention Technology Transfer Center Network is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration. The Great Lakes PTAC has a focus on providing high-value training and technical assistance targeted to local needs in Health and Human Services Region 5, which consists of the states of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. Thank you to our Partners in Change for your sponsorship of the INARMS Symposium. Without further ado, I'd like to introduce our CareSource team speaking on developing best practices in community reentry, the CareSource model for the formerly incarcerated. We have 4 exciting presentations today, and so I'll start with the first presenter's bio, Sara Hale. Sara began working as a criminal justice liaison with CareSource in August 2019. Sara has previously worked at the Indiana Office of Medicaid Policy and Planning and as a navigator at a community mental health center. Sara has a Bachelor of Arts from Northwestern State University of Louisiana, where she focused on psychology and literature. She is passionate about Medicaid policy, criminal justice reform, and improving social determinants of health. Sara is an outspoken advocate for the justice-involved individuals she currently serves. Please welcome Sara Hale. Sara?
Hello, and thank you for allowing us to speak during the 2020 Indiana Annual Recovery Month Symposium. Today, our CareSource team will be discussing our reentry and transitions programs, as well as our life services program. Next slide. Could you advance the slide? Okay. Today we will be discussing 6 different topics: the challenges of reentry, CareSource and the reentry population, serving the returning citizens of Indiana, coordinating behavioral health services, our life services program, and how we go about measuring success. Next slide. But first, let me tell you a little bit about CareSource in case you're not familiar. Next slide. CareSource is a nonprofit managed care leader. Our mission is to make a lasting difference in our members' lives by improving their health and well-being. We currently serve members in 5 states with our Medicaid, Medicare, and Marketplace plans. Next slide. Some concerns of our returning citizens are reflected in this word bubble. They have obligations to their family, friends, and parole or probation officers. They are trying to secure permanent housing, put food on the table, and attend to health concerns. All of this is happening while they are unemployed or just starting a new job. Most of us would be overwhelmed just facing one of these concerns. Our returning citizens are frequently facing all of these concerns at once. Next slide. Statistically, the health status of returning citizens is much more at risk than other Hoosiers. There is a higher risk of hepatitis C, HIV, and substance use disorder. Mental health and behavioral health diagnoses are also a concern. Other chronic health conditions like hypertension, obesity, and diabetes are more prevalent among this population. Next slide. When we are talking about our reentry population, we know that these individuals face a lot of challenges when they're released. Statistically, they are at risk when they attempt to re-enter their communities. Our reentry team is working hard to change the statistics for people released from IDOC facilities. Next slide. As we outreach to recently released individuals, we are assessing the 3 general concepts listed here. We use multiple tools and questions to identify how these concerns apply to each member, find them the best care possible, and continue to follow up to ensure their needs are being met over time. Next slide. Let's take a moment to dive into what our reentry team does and how we operate. CareSource's reentry team is composed of 3 full-time criminal justice liaisons and 1 part-time community health worker. We are supervised by the transitions team and work within that team at CareSource. The 3 criminal justice liaisons are fully dedicated to working with the reentry population in Indiana. When there isn't a pandemic, we visit 15 different correctional facilities across the state and conduct our pre-release classes with offenders. We work closely with IDOC and FSSA. Obviously, we're coming from the perspective of a health insurance company, so many of our efforts are wellness-based, but we are also concerned about social determinants of health for each member. Next slide. Our reentry program collaborates with community partners across all 92 counties of Indiana. These community partners help you provide supportive services which aid in the transition back into communities. When there isn't a pandemic, we attend the Marion County Reentry Court on a weekly basis. We utilize CareSource's care management program, which supports members with physical health and behavioral health concerns, but also identifies those social needs that may need to be addressed. Later in this presentation, we will discuss our JobConnect Life Services program. We have also hosted and participated in the COPE Cost of Poverty experience across the state.
Thank you so much, Sara. Our next CareSource presenter is Shenicka Pearson-Moore. Shenicka is a criminal justice liaison in CareSource's Indiana market. Shenicka has more than 25 years of medical experience with a combined total of 14 years experience in the Indiana Medicaid arena. Shenicka started her career at CareSource in January 2018 as a community health worker in the transitions department. Shenicka was promoted to criminal justice liaison in January 2019. It is Shenicka's responsibility to provide HIP 2.0 education to justice-involved citizens prior to their release. Shenicka and the CareSource reentry team do so by facilitating pre-release classes in 15 of the adult Indiana Department of Correction facilities. Upon release, Shenicka sits with care coordination, which includes completing assessments, connecting members to primary care physicians, specialists, mental health and substance use disorder providers, as well as referrals to community resources. Shenicka believes that members that are truly connected to services have a higher success rate and a lower chance of recidivism. Shenicka?
Thank you so much. Again, my name is Shenicka Pearson Moore, and I'm one of the criminal justice liaisons for CareSource. I want to talk for a moment a little bit about the reentry team roles. So as Sara stated, there are 3 criminal justice liaisons and 1 part-time community health worker. I'll just reiterate that prior to the pandemic, we did present at 15 of the IDLC facilities pre-release. Upon release, we do complete the health needs screenings, criminal justice transition plan, and conduct 30, 60, and 90-day follow-up with our reentry members. Prior to the pandemic, we also attended reentry-related community events. Our community health worker assists us with the facilitation of pre-release classes. She also conducts telephonic outreach to members to link them with much-needed resources like food pantries, housing, clothing, shelter, and making the necessary referrals. Next slide, please. Our reentry operations. Pre-release, we educate the incarcerated individuals regarding the Indiana Medicaid and HIP benefits and inform them about CareSource reentry programs and other services offered. Post-release, we identify our members through various sources. We do get lists from the Department of Corrections letting us know when members are being released, what date. There is a scope for finding out whether or not the members will be with CareSource or one of the other managed care organizations. Once our members are identified, then we do engage them. We also receive assistance from our transitions team, which I will speak about in just one moment. Next slide, please. Providing the necessary referrals. So we assist members with referrals to specialists. We assist with finding transportation for medical, behavioral health specialists, or even radiological exams. We make internal referrals to our one-to-one case management team, medically frail for additional Help Indiana plan benefits, to My Strength, to CareSource Life Services and JobConnect program, which Cord will speak on momentarily. And we also educate members regarding the 24-hour Nurse on Call and CareSource Rewards program. And then again, we make those external referrals to for community resources. Excuse me, I'm sorry. Coordination of care. When a member is released from incarceration and their coverage is suspended, we will do a conference call with them to the Division of Family and Resources to help get their HIP coverage activated. We provide information and referrals to those members while their coverage is still suspended so that they can receive the necessary care, such as referrals to a federally qualified health center or community mental health centers. Once their coverage is activated and it's been established that the member will be with CareSource, that's when the reentry team steps in to engage. We highlight plan differences such as the difference between HIP Basic, HIP Plus, and HIP State plan, and stress the importance of paying their HIP Power account contributions. We review care gaps and educate members regarding preventative screenings. We assist them with obtaining prescriptions, home medical, and durable medical equipment. And again, we do that targeted follow-up at 30, 60, and 90 days. Next slide, please. Expungement. CareSource will cover up to $500 for the cost of expungement for a CareSource member, but the following criteria must first be met. The member must not have any pending charges in any state. They must pay all applicable fines, fees, court costs, and restitution. They must wait the required amount of time per offense per law. They have to obtain a letter of approval from the prosecutor's office, and they must either actively participate in the CareSource Reentry or Life Services JobConnect program. Next slide. Our transitions program. So I'm going to speak briefly and give an overview about our transitions program. Just as the reentry team assists with reentry members, transitions assist with members that are being discharged from an inpatient setting. The transitions team consists of a multidisciplinary team of nurses, social workers, and community health workers who often work collaboratively to provide transitions of care. Next slide. We promote the emergency department diversion through assisting the member in establishing a medical home or selecting a primary care physician, educating the member on what constitutes an actual emergency as well as alternatives, like calling their primary doctor after hours, contacting 24-hour nurse on call at CareSource, or presenting to an urgent care instead. Referring members for medication therapy management if we identify that they don't understand their medications. For members who've had a behavioral health follow-up hospitalization, we ensure that they've had a 7-day follow-up appointment with their community mental health center or behavioral health provider, and Edna will speak on that momentarily. Next slide, please. Case management. Next slide. Our CareSource Care for You or case management team is a multidisciplinary team that is regionalized with a focus on subpopulations. There are 7 regions throughout the state that contain at least one nurse, a social worker, and a community health worker in each region. The focus on the subpopulations include maternal child health, behavioral health, chronic disease, and acute medical conditions. Next slide. Our population health approach exists on a continuum. We start with assessing and identifying the member's needs, which includes consideration of the member's cultural needs and level of health literacy. Level of care and frequency of outreach is determined on members' comorbidities and needs. We work with the member to develop a member-centric care plan. The member's care plan is reviewed and updated with the member and provider throughout the case management services. Next slide. Excuse me. Our CareSource strategy, the empowerment model promotes self-efficacy by providing the member with tools for self-advocacy and self-management, while recognizing how social determinants of health impact an individual's ability to manage their medical and behavioral health. The empowerment model focuses on competence rather than deficits in the individual or social and functioning. Next slide. Coordination of plan interventions. Care coordination for members may include assisting in scheduling a follow-up appointment with the primary doctor, obtaining durable medical equipment, helping the member to understand their health benefits, reviewing care gaps, scheduling preventative screenings, and/or locating a primary care provider or specialist. And last slide, please. And in our Care for You or case management model, the member is in the center of the care coordination and makes the decisions as it relates to their overall health. The care manager promotes the two-way communication. I will now hand it over to Edna Sandersmensah, who will discuss the support provided to members accessing behavioral health or substance abuse treatment.
Thank you so much,
everyone.
Shenicka.
My name. I'm sorry. Go ahead.
No worries, Edna. I'd like to introduce Edna Sandersmensah, who Edna has a Bachelor's of Science from Ball State University and a Master's of Social Work degree from Indiana University, Purdue University in Indianapolis. She is a licensed clinical social worker and has over 15 years of experience providing case management, utilization management, crisis management, therapy, and care coordination services in the areas of homelessness, inpatient, outpatient, foster care, home-based, corrections, and managed care environments. Edna began working at CareSource in 2019 as a behavioral health initiative lead. Thank you so much for joining us, Edna. I'll pass it back to you.
Thank you. Okay, hello everybody. I'm going to share with you ways that our behavioral health team works with providers to assist our reentry members. Next slide. So first I'm going to talk about behavioral health strategies to help improve our members' health outcomes. For members that are inpatient, the behavioral health transitions team work with both inpatient and outpatient providers to make sure our members get their follow-up appointments after hospitalization within 7 days as required by NCQA and address any barriers. We keep in touch with the members for about 90 days because this helps to ensure the member continue their momentum with their recovery and also helps to prevent readmissions. We share data with our providers to improve the outcome of our members. In our provider portal on the website, some of the things providers can access include looking up prior authorizations, checking claims, view pharmacy information in real time, check ER visits, admissions, and other information can be found there. We also monitor data to see how our providers are doing, and if there are seem like any ongoing issues, then we contact the provider and collaborate to help improve the issue that needs to be taken care of, such as Shenicka and I had mentioned earlier about the 7-day appointment after hospitalization. So if a provider is getting a low number of members getting their visits within 7 days, then we will outreach to the provider and address any barriers that might get in the way. Care coordination is available to all behavioral health members through our Care for You case management program. We have care coordinators throughout the state of Indiana in 7 regions. It includes social workers, nurses, and community health workers in each region who can better identify resources to meet the needs of our members. We also do virtual visits with hospitals and community mental health centers. We were doing them face-to-face, but because of COVID, we are doing them via WebEx. So we provide education on HEDIS measures and collaborate as needed. We also offer on-demand webinars to providers such as MAT, the medication-assisted treatment, depression, and cultural competency when serving reentry communities. Next slide. So these are some of the requirements for members to become a part of our case management program. I'm sorry, did we skip a slide? Can you go back one? Can you go? Thank you. So these are some of the requirements for our case management program. So members are provided case management based on behavioral health triggers, such as a serious mental illness, where it could be schizophrenia, psychosis, bipolar disorder, major depression, for suicide, self-harm behavior, if they have a behavioral health diagnosis, pregnant or postpartum. Also, if they have a substance abuse hospitalization or psychiatric hospitalization. So these are ways that our members get into the program. Next slide. And so this is some of the things that our case management teams will do to assist our members, our reentry members. The transitions team, as I said earlier, behavioral health provide members with at least 90 days of case management with several touch points during that time. They facilitate outpatient programs, IOP, PHP, individual, group family therapy, and coordination of MRO services. They also provide notification to behavioral health providers and PMP of a behavioral health admission within 5 days. They assist with finding medication-assisted treatment programs, and that's MAT. And MAT is a top treatment option for opioid abuse disorder and remains the gold standard in addiction care. Next slide. So lastly, I want to make you aware of the medically frail program. Our HIT members can receive enhanced services after being assessed and approved. They can self-refer by calling our member services line or be referred by a provider. Some of the added benefits that they can receive include vision, dental, transportation, chiropractic care, and enhanced prescription coverage. For our behavioral health members, they must have one of the diagnoses in this middle column here, the alcohol and substance abuse, mental health, mental illnesses, including major depression, schizophrenia, bipolar, or PTSD. And that's all I have. Thank you. This concludes my information.
Thank you, Edna.
From court.
Greatly appreciated. Cord Hale is a criminal justice liaison employed through CareSource in Indiana. Cord's primary focuses are performing several key roles to ensure returning citizens are assisted in accessing healthcare and other internal and external resources to help in their transition to the community. Selected as the first criminal justice liaison in 2018 for the Indiana market, Cord was tasked to begin HIP 2.0 education in 2 pilot locations within the Indiana Department of Corrections. Cord has a master's degree in strategic management through Oakland City University and a bachelor's degree from Ball State University. Cord, I'll turn it back over to you.
All right, thank you, Sunny. I have the pleasure of talking about a program that makes CareSource unique, I believe, from our competitors. Our JobConnect program is a unique service offered free of charge to CareSource members who are interested in finding employment, job training opportunities, or returning to school. Next slide, please. The vision of the JobConnect program is to promote a holistic foundation to address the social determinants that impact a member's health and overall well-being. Our mission is to make a sustained impact on the lives of our members. An example of this is our JobConnect program is available to our members for at least 2 years or more, depending on that person's individual plan for self-sufficiency. Next slide, please. The social determinants of health covers these areas: economic, housing, education, social, and nutrition. Our JobConnect program attempts to address these needs as members search for or advance in their employment pursuits. Next slide, please. As you can see from this slide, the social determinants of health can have a great impact on the lives of members when these areas are not addressed. Next slide, please. What makes our JobConnect program so unique? It is that we can currently address a member's healthcare needs along with addressing those social determinants that might be affecting that member. Secondly, we provide an individualized approach that includes risk assessment, case management, and coaching assistance. And then lastly, we partner with over 200 employer partners around the state to help our members get employed in the area of the member's choice. Next slide, please. Our JobConnect team is comprised of 8 life coaches, 2 enrollment specialists, and 2 employer relations specialists. The program covers all 92 counties in Indiana. Next slide, please. Our program takes a no wrong door approach to serving members. We start where the member is to chart his or her journey. Next slide, please. The goal of the JobConnect program is to not only help members with finding employment, but to rather embark on a life transformation plan that will create a pathways towards health and self-sufficiency. Next slide. As a result of members' involvement in our JobConnect program, our participants have experienced a positive impact on their overall health outcomes. As an example being almost 81% have received preventative care. We've seen a reduction in emergency room use. And so all those numbers are trending in the right direction. Next slide, please. Today, we've had 536 members who have opted into our JobConnect program. Of those 536, 308 are employed, and we have close to 90% that have retained employment. We believe that retainment of employment is due to matching members to jobs that they want. Next slide, please. Our JobConnect program hopes to decrease the odds against returning citizens as they look for employment. As you can see from this slide, close to 40% of returning citizens do not have a GED or high school diploma. Some, close to 60% of employers surveyed stated they would not consider hiring someone with a criminal history, and many job avenues are closed to those with a criminal history. So the JobConnect program exists to decrease those odds against our members. Next slide, please. Individualized training and service planning are taken into account for each member. Everyone is unique. Next slide, please. Quality and analytics. Next slide, please. We have regular and ongoing tracking of certain metrics to help gauge the success of our reentry program. Some of the metrics we track include the number of members engaged versus non-engaged, completion of the health needs screening, medically frail determination, preventative care, and tobacco use, just to name a few of the metrics that we are tracking. Next slide, please. This one. The reentry program has to be operational for at least 3 years before we can effectively measure the impact of reducing recidivism rate. However, the early numbers have been promising in regards to our reentry members and their health outcome. As noted by this, close to 40% are more likely to have engaged in some type of screening. 20% are receiving preventative care, and of course, emergency room decrease. So the early trends are promising in terms of the impact of the reentry program. Next slide, please. And then we're going to leave this slide up, but this is if you want to contact any one of us on the team, Shenicka, Sara, or I. Our contact information is on the screen. We also have an email address. This is to our reentry mailbox. This is monitored every day, so if you have any questions, referrals, or you just want to outreach to us, we certainly will be excited to have you to reach out to us. So thank you very much.
Thank you so much. I'd like to also introduce Gregg Pieples to join us for the CareSource question and answer time. Gregg Pieples is the manager of behavioral health programs for CareSource. He has a Bachelor of Arts from the University of Cincinnati and a Master's of Social Work from the University of Kentucky. This marks his 30th year in the field. He has worked extensively with the homeless and substance use populations and was most recently the Director of Addictions at a community behavioral health center in Cincinnati. I'd like to welcome the entire CareSource team back for a robust round of question and answer that will last us the next 10 minutes before we introduce our next presenters with the Jasper County Jail. First up, the audience attendee has asked, great explanation of pre-COVID processes and transitions. Could you elaborate more on what does the COVID response look like, as there are still individuals being outreached to during this time?
I'll take that. This is Shenicka. Long and short of it, everything is telephonic. Everything that we can do over the phone. There's a lot more faxing and emailing, but gratefully we've been able to get the job done, and I would say have more of a success rate because we are all based at home now versus out doing the majority of the presentations. We're able to concentrate and focus more on our members.
Thank you so much. Our next question is regarding eligibility. What is the time restriction, if any, upon reentry that the individual may request assistance through CareSource?
I can take that one. They can really do it at any time. So about 60 days prior to an individual's release from incarceration, IDOC is going to do an application on their behalf. That application kind of goes into like a suspended status where they're holding the application until they're released. The individual, once they're released, a lot of times FSSA or Department of Family Resources, they will go ahead and process that application because the release date will be sent over from DOC. But if for some reason it doesn't get processed, you know, that's why we want to help along with that. But they can call us at any time. So if it's been, you know, 2 days, 2 months since they're released, we can still help them. If it's been a year or more, that can get a little bit fuzzy, but we try to get people just as soon as they're getting out.
Thank you for that response. Additional program questions include, how long has this program been in place, and in what counties is this program available?
Yeah, I'll take that. The reentry program actually started in January of 2018 as a pilot program. It was initially scheduled to go for 2 years. Thankfully, we've been extended another 2 years, and so we've been going on for the last 2.5 years. And again, we serve all 92 counties. We have staff that is strategically placed throughout the state. So most of our work is done telephonically, but if we get members that need a little bit more one-to-one care management or possibly life coaching, then we will do outreach and referrals to those staff in that region that those members are in.
Thank you so much, Cord. And here's a specific question regarding transportation support. Could you provide a little bit more detail on the social determinants of health on what transportation support looks like, and especially for those with substance use disorder, as it's considered access services concerns?
Yeah.
Go ahead.
Go ahead.
I was going to say, we do have a transportation vendor who works with us. So if you are a CareSource member, you just call up this transportation number, and we provide rides to and from appointments. I have some members that I know off the top of my head that I'm working with right now in Newcastle. They go to a medication-assisted treatment facility in Muncie. For both of these members, we pick them up in Newcastle, drive them to Muncie, drive them back home. In regards to the social determinants of health aspect, during the pandemic, CareSource is also offering free transportation to grocery stores. So you can use that transportation service that has generally been set just for doctor's appointments and medical things. Right now, during the public health crisis, you can use that to go to the grocery store or to the food bank or food pantry. I believe it's up to 4 times per month per member at this point.
What a wonderful service.
And I would, Sunny, this is Cord, I would also add too, in part of our life services in terms of transportation, for those members that are enrolled in that life services program, they have access to transportation to educational opportunities, job training opportunities, that first interview on the job. If they don't have the transportation to that, then they can use our transportation service to be able to get to those opportunities.
Thank you so much, Cord. Really appreciate the great services being provided and the information. A couple questions on quality and metrics. May we ask, and would you share CareSource's recidivism rate?
Yeah, we are. That is a statistic or a number that we are still working on. I know that through IDLC, they've measured recidivism by the 3rd year, and so this is year 2.5 years into this program, and so we really don't have that statistics yet. But we hope sometime next year we can get a better handle on how our impact of our program when it comes to recidivism.
Fantastic. So audience members, stay tuned for next year's INARMS Symposium for additional data. If you have additional questions, please go ahead and type them into the question pane. We have the wonderful CareSource team for a few more minutes. There are a few questions being typed in, so we'll give everyone just a few more minutes or rather a few more seconds to finish their thoughts.
Sunny, this is Gregg. I'd just like to make a quick comment that just expressing the importance of this population for CareSource across all of our markets. Criminal justice, we know, is a vulnerable population, especially as folks come out back into the community. And so we put a lot of resource behind this. In each of the markets that we're in each of the states, we have subject matter experts on this topic. We know that these folks are ones that typically struggle to get back into service. We know simple things such as quick outreach and just contacting members have huge impact on not only making it to outpatient care, but staying in outpatient care, and have better outcomes. So this is definitely an area that we spend a lot of time and effort coordinating across each of our markets.
Thank you, Gregg. That's so important to understand the differences in each market and the local community health needs and also employability needs that are evident within our reentry population. What are some learnings that you've taken over, or what are some learnings that you have looked at over the last 2 years of how the Indiana market differs, and where are there additional improvements that you would like to see in the next years?
Well, I'll take some of that. I think, especially with the criminal justice systems, they're all different. I mean, every jail, every prison works differently. I think that Indiana overall is very well coordinated compared to some of our other markets we're in. You know, especially with things like getting into substance use services. I think that as a general whole, although we can always use more providers, the access to treatment is much smoother in Indiana than we haven't seen in other areas. Like, say, for instance, Ohio, we have probably 10 times the number of providers, but the coordination isn't always there. So in general, I would say Indiana does well with coordination. Again, the criminal justice itself is very unique. In Ohio, we're actually working on a pilot to track any of our members that go into jail on any particular day. We can track those now. We're piloting that in a couple counties. We hope to put that out to each of our markets, hopefully within this next year, so that our care management teams will know if any of their members go in or out of jail, so we know where we can connect to folks as quickly as possible.
Yeah.
Thank you,
and
Gregg.
Sonny, this is Cord. I wanted to add to piggyback what Gregg just mentioned, that area that this particular pilot program focuses on those coming out of the state prisons. And so certainly as a team, if we had our choice, we would certainly like to see this program expand to the local and county jails in all 92 counties. So that is something that we would really love to see this eventually head to, is into all the county jails around the state.
Great insights, thank you. And certainly from the care coordination side, the state has heavily invested in trauma-informed, recovery-oriented systems of care. So it's great to hear that providers are seeing that care coordination come to be a benefit to all programs. 2 more questions before we close for today. One is, could you talk a little bit more about, for individuals that are seeking medication-assisted treatment, what the process is both prior to release and post-release?
I'll speak to that, or Shenicka, I'll let you go ahead.
Okay, thanks, Sara. So prior to release, there's not a whole lot that we can necessarily do, just because, of course, while the member is incarcerated, they can't have Medicaid coverage. However, if it is a complex member, and if the case manager inside the prison deems them as complex, we just started a pilot with Newcastle Correctional Facility that we can start speaking with members prior to their release to try to get care coordinated, get their provider set up prior to their release. The downside of that is not all members come to CareSource. Because of the pilot program that Cord mentioned, if a member has been incarcerated for 2 years or more, they are supposed to come to CareSource. But if they've been incarcerated 2 years or less, and they were with another managed care entity prior to their incarceration, they will go back to that managed care entity. So we do as much as we can up until the point of their release, and then finding out which managed care entity that they will be with. If it is established, we know ahead of time that they're going to be with CareSource. They've been incarcerated for 20 years. Again, we will go ahead and coordinate that care, get them connected to a MAP provider, find one in their area, a contracted MAP provider in their area. If need be, go ahead and get transportation set up so that when they're out, it's seamless as far as the treatment that they receive.
Comprehensive. Okay. Thank you so much for the insight, Shenicka.
I wanted to add just a second to that. As I was saying, you know, I know of 2 people I'm working with right now, and basically for both of them, it was just a matter of a few days. Once they got their Medicaid activated, they got into that medication-assisted treatment like calling on Monday, having an appointment by Tuesday or Wednesday. So that turnaround time has been really quick in my experience. And so I've been really impressed with how quickly people are able to access that medication-assisted treatment.
Thank you, Sara. The last question is focused on employability. As we all know, jobs aids, skills development, workforce development, that itself is a full-time program. What are you supporting today as far as employability and job positions, and where do you look to see extension programming to occur in the next years?
I'm not sure if I completely understand the question, but what we do try to do is work with a lot of our community partners to help with our members getting employed or getting them into job training opportunities. There's a program such as Build Yourself Indiana, which is a construction training program offered throughout the state of Indiana. There are other programs such as New Beginnings, which is offered through Goodwill of Indiana. But one of the keys that we really try to focus on to get our members employed is connecting those community resources, those programs that are out there. And certainly we use the Work One office, Build Yourself Indiana, programs like that, Next Level Job, things like that. And we found if we can get our members, particularly those reentry members, if we can get them the skills that employer needs, that typically will help to get those guys a foot in the door into employment.
And I'd just like to add to what Cora was saying. We have CareSource has almost 200 employer partners, and of those partners, over half of them are second chance employers. So they know that we have the reentry program and that we have members with the past, and they're willing to give them a chance based on our work.
Thank you for creating such a robust partnership in support of our reentry community. Well, Sara, Shenicka, Edna, Cord, and Gregg, thank you so much for your time and presentation today. We are going to change gears here to hear from Dr. Chad Pulver and Sheriff Patrick Williamson with the Jasper County Jail, focused on whole person approach in community reentry. Dr. Pulver and Sheriff Williamson, can you hear us okay?
You can, yes.
Excellent. Well, sirs, we have your PowerPoint up, and I'll transition it back to you.
All right, thank you. We'll kind of start out with who we are. We're a sheriff's office located in the northwest part of the state. We're just south of Lake Michigan, approximately 30-40 miles to the northern half of our county. And we're a smaller county with about 36,000 residents. Our jail is approximately 112 bed facility. We have 24 correctional officers. So we're a small community with not a lot of resources in the area of mental health and addiction. So we've kind of had to pioneer this ourselves. And one thing we learned in 2001 when methamphetamine entered our community was we couldn't arrest our way out of the situation, regardless of how many criminal arrests and how many dealers and things like that we pursued. The problem it just continued, and it grew to also include heroin and other drugs. And we're to a point, what are we to do with this? The whole community is wondering what to do with this. And this epidemic of addiction is just really touching so many people in our county. So looking back, I've been the sheriff for 2 years now and been in law enforcement for approximately 33, 34 years. And I really don't ever remember our jail being involved in rehabilitation. And since I've been involved in the Sheriff's Association and seeing a lot of other smaller jails, we house inmates, but we really don't prepare them for community corrections, DOC, work transition back into the community and those types of things. So we've had to kind of pioneer this ourselves because it just isn't available in our area. So one thing we noticed was we had a lot of unrest with our inmates, as we've had over the years, a lot of boredom, lack of constructive activities in our jails. We house people for, just a few hours to maybe 2 years, and but very few ever go over the 3 to 4 month period. We notice that these inmates don't really have a lot of hope, and what hope they do have is really kind of unrealistic hope, hope that's without any plans, things of that nature. So we see this continual cycle of going out of our jail, coming back to our jail, just continual ineffective as far as help with the current system that we have. So we decided to reach out. Some of you may know that St. Joseph College in our jurisdiction had a situation where they had to close the college down, and I was made aware of their doctor of psychology, Chad Pulver, and that maybe it'd be a good ideal to partner with him and look at an addiction program for our jail. And we're going to stay with this first slide because I'm just kind of leading up to it. Dr. Pulver agreed to meet with me, and we started just kind of a process of trying to get something going with our jails. So our community realized it when we approached our commissioners, judges, probation. I mean, everybody realized it, but we needed to get something started. So our commissioners actually funded this program through a jail fund that they weren't really used to spending the money from. It was about a $400,000 fund, and our program was going to start out about $150,000 a year. So we did that, and in my opinion, we needed to incorporate, and this is my uneducated opinion in psychology or mental illness, addiction, and so forth, only what I learned in the past few years. But I felt like our inmates needed hope. They needed a job. They needed housing. They needed transportation, all these things that is very difficult to get when you leave a local county jail. So in conjunction with the JSAT, I pretty much jumped on board with about anything I could get into our jail to help with rehabilitation. We have a large garden that's been going for 2 years. Most of these inmates have never worked in a garden, tasted fresh garden produce. So we kind of taught that. We also brought the Purdue Extension in to help teach gardening and about soils. We brought the Purdue Extension for home ec into the women, who a lot of our women don't understand nutrition for their children at home. They don't understand cleanliness. There's a lot that they don't understand. Really helps our inmates not only mentally, but it kind of helps them feel needed. We started discipleship classes, faith-based. We started a full worship service on Thursday mornings. I felt that just my own experience in the Christian realm was put me in a good frame of mind weekly, and I felt it'd do the same with our inmates. Job placement. We fill out online applications, and we take inmates to actual interviews to help them secure jobs. We also here recently we actually have a peer support group called QRT that's come into our realm, and they meet with inmates 30 days prior to also help in housing, help with transportation, get jobs, work out those issues as far as driver's licenses and things like that. The doctor, who's very innovative and forward thinking, has offered to us that, and we actually use this. We actually have our inmates who leave our jail that are involved in our therapeutic program, which is coming up, and it's going to be explained. But these inmates are allowed to come back into the jail, and for 90 days, 1 day a week, 12 weeks, participate in group therapy. I don't know of that going on anywhere on a jail campus in a local county jail. So we're involved in a lot of that kind of outreach and rehabilitation for our inmates. We also secured a grant through the ICJI for Dr. Pulver to help, displace the amount of money that we're spending on the county. So that's something that's now coming online due to COVID. We're a little late on that. So So I wanted to kind of turn this over to Dr. Pulver from a JSAP point of view, and he can kind of explain the particulars and all those things that's happened from this point of us getting started. So
thank you, Sheriff. So we did begin in 2018. We began February of that year, and the initial steps were literally me walking in the morning of that first day and Sheriff taking me around to some of the inmates who at that time were in the kitchen working. And we talked about what our ideas were. We talked about what we thought we might be able to do to help them and prepare them for what could be coming next. And we started with 2 inmates that day. They said, okay, yeah, sure. And they came down, and that became the process for my communication with the jail administration staff. I worked closely with the sergeants and the commander. I worked closely with the sheriff, but we had to try to create some type of day-to-day routine. And so once we started to figure out who might be good to approach, who might be fitting for us as far as what we might be able to do in this program and what we're really working toward, we did base this on the idea that any type of incarceration treatment, it does help them, but ultimately we're trying to improve their transition out and the likelihood of them finding the treatment that they need afterwards and the connections to those resources afterwards. If we can make a positive hook with them, get them to experience a positive treatment experience for us with them, it might improve their chances of being successful on the outside or seeking that support that's going to be needed, considering that they were coming to us from the jail itself. So in 2019, a year after we had started, we started to add some new wrinkles to the program, and we'll get into more details of those. But one of the major improvements was in May of 2019, we actually created a worker pod. Any member who was in that pod was part of the treatment program, and they were given extra responsibilities for the jail. Some of it was working in the kitchen, doing laundry, cleaning, as well as potential of outside detail, which the sheriff had mentioned earlier. COVID did switch some of these around for 2020. We had laid plans to make a much larger push to get a larger amount in the worker pod, as well as being able to provide them opportunities off campus a little bit more frequently. But with the virus, it certainly shut that down quickly, and so we've had to adjust in a number of places. Next slide, please. We actually had a number of coordination and with the correctional officers on a day-to-day basis. I'll wait for the slide. Slide, please. So we actually worked internally with a coordination with our officers, and ultimately what we were trying to figure out was who were fitting as inmates to come down and be part of the program, who was going to benefit the jail, who was going to benefit themselves, how it was going to help the community members or the families connected. And so those referrals early on could have been the inmate could have requested. It could have been from a correctional officer coming to me or mentioning to me something that had happened. It could come from one of the jail administration or from the nursing staff here on campus. And so what we were trying to do is be as open as possible to anyone, as well as paying attention to when life changes started to occur for the inmates. It's not uncommon for people to receive bad news or other pieces of information that come to them, and that changes their experience in the jail. And so our COs are very connected to what's going on in the different pods. And so I relied on them heavily and still do rely on them heavily to provide me with information about information maybe has come in to the inmates, something might have happened in the court system, something might have changed for an inmate, and that might lead to me doing an informal walk up, ask how things are going, offer them the opportunity to fill out an application if they do want to be part of the program. This year, we were approved to have a change of position for a correctional officer to actually work directly with our program. So we have someone who is going daily and checking in with those who are connected to the JSAP program, checking oftentimes with releases or holds that they might have with other counties, sometimes making calls and helping them fill out applications or transporting them to interviews that might happen. And so that has provided JSAP program with an extra piece that is much more embedded into the system, not only with the correctional officers and the jail administration, but also daily and frequent contact with the inmates. Next slide, please. One of the things that the sheriff has done really well in coordination with JSAT is reaching out to our community resources. The sheriff has really strong connections to employment opportunities. He created a number of housing connections that we're trying to still work on. And one of the things that we have found throughout this process is making sure that transportation, especially in our rural county, transportation becomes very difficult. A number of our people that we're working with, they don't have access to a license. And so when they get out, it's not just can they go and, we're talking so fast the lights went out. So we can't just release them and hope that they're going to find transportation. And to walk to work is nearly impossible for many of the people. Riding a bike would take still a long period of time. And so trying to find some of those answers, this is what the program early in the process has started to bring to the surface are these issues and dilemmas that we're trying to answer and to be part of the solution for our community. And so we did reach out to St. Joseph's College. The sheriff created an opportunity for inmates who were employed to be able to use facilities there to pay for rent and to stay on campus. And he also coordinated with the county trustees that they would offer that first month's rent as well as the deposit that the inmate over time would pay back to the trustees. So that way the location wasn't offering up free of rent. The individual was responsible for that, but did have some scaffolding to help that person get to being even as far as that rental and that ability to avoid being homeless and in fact have a very nice place to stay. We are currently trying to improve what we have as far as transition out of jail for both men and women, but specifically for the women who leave our facilities, our county really lacks some of those resources. And so we're currently working diligently to try to find housing for those women, maybe some childcare for the women and the children that they have connected to them. And so we're continuing to build those connections with employment, hopefully with some daycare. And then again, it goes back to transportation. And so the more that we can do that, our county has a lot of acreage, a lot of mileage to cover, but we have very few people. And so those public transportation opportunities are very limited for us. Next slide, please. So our program is based on the whole person. We really do, from the beginning of the screening process, we do ask them about mental health and their substance use. We ask them about their employment. What is their employment history? How long have they worked? It is not uncommon for some people to come in with an extensive work history and have a number of years where they've been very successful, and then something has just derailed that process. And then we have the other end of the spectrum where individuals have been so much part of the legal system that they have not even worked at a facility or some type of employment location for longer than a few weeks at a time. And so we're trying to find out where they are on that spectrum, trying to give them as many opportunities as we can as they're leaving. And then the overall is we want them to be connected to the residents. We want them to connect to the transportation, and then overall the life transitions of, if you're a mother or father, are you reconnecting to your children? Are you reconnecting to your extended family? So that way, when you walk out of here, there may be a support network waiting for you. And if that's not the support network, then we know we need to help you rebuild that. So that's when we take a whole person approach, we're really trying to take in an idea of what are this person's strengths personally? Where are they finding their support? What do they have intact? And what do we need to build around them? And then help them educate themselves for what are the triggers that help them sidestep some of those problems, and what are the things that tend to pull them back into very negative or toxic situations for themselves. We spend a lot of time trying to reframe what they're doing in their own situations, and then at the end, when they transition out, those responsibilities to being able to perform better in the employment. Excuse me. As I mentioned, we did start with 2 inmates in February of 2018. And currently with COVID and our pretrial release, our population has started to shift. And so we are currently at 30% of our inmates are currently involved in the program. But at times of the year, we are sometimes at 55, even 60% of our population is actually a part of our program. And again, this is completely voluntary. There is no one that is mandated to be part of this. There's no one, thank you. There's no one that is forced by the administration, by the court system to be a part of any of our sessions, or if they don't want to partake, they are not asked or they're not forced to come down and be part of what we're doing. The worker pod was, typically is between 8 to 12 men in the pod at this time, and they do have different shifts. They work day to day, some in the kitchen, some cleaning, some doing the laundry. And then the garden that the sheriff has talked about, the garden has been worked on not only by the male inmates, but we also have females that are part of the program are allowed to go out and work in that facility as well. We are currently trying to work a female pod to be able to do some type of work on the weekends. We have not set up that that work detail yet. So we do, the cognitive behavioral treatment really is the linchpin and the backbone of how we put things together. Next slide, please.
I'd like to add to that, Doctor, that we have 60 inmates average right now. We had 80 before the COVID hit, so that gives you an idea of what our population is and the percentages you see there. So.
The data that you have on your screen there for participants, since we turned in our slides, we've actually upped some of the data that we have, and so I wanted to give you the most up-to-date with what we have. It resembles what you see in front of you, but in 2020, we have 60 screenings that we've done already this year, compared to in 2018 when we first started. We did from February until December, we had a total of 30, and so the correctional officers, as well as the inmates, word of mouth, as well as us just being now part of the community a little bit more, people come in and they will sometimes, while they're sitting up front and booking, actually ask for an application. And so the days in between being in jail and getting that first application in has really dropped significantly, which is what we find a very positive thing. The average age of individuals who are coming to be part of our program is over 30. And you can see that around 78% of the people who are part of the program are males, which is pretty reflective of our population, males to females. The average session attendance, this includes someone who might have come in for a screening and only did that screening and left, is still set 6.71. So on average, when people come and are part of our program, they're staying for over 6 sessions as part of that, whether it's a release or maybe they get tired of doing it and so they stop. But overall, when you take into account the number of people that are here and the number of people we see, and some of those that don't want to be part of it, once they come down and they speak with us for an intake, it's still 6 sessions. And what we found is that 5 tends to be that breaking point. Once they're in over that 5th session, they start to see how it can help them, or they start to see some value for themselves or those that they might be connected to. So we find that very positive. Next slide, please. On this one here, I just wanted to provide you some of the data that we have collected for the releases. So I just used the 2019 release data just because that allowed us to actually have some months where people were working with us in 2018 and then through the full year of 2019. And so that way we could connect you to what we have seen as far as recidivism and those who have continued to stay out. And so of those in 2019 who were released, we had 34 total that were released. And so when those males, the 20 males, they averaged 10 of them of the 20 actually had over 5 sessions in our treatment protocol. And for the females, there's 7 of the 12 actually attended 5+ sessions. So we felt very strong that this was connecting to those people. And even when they were getting the release, we had enough time with them to show some connection with them. The reoffense is the next part. Of the 34 that have been released, 4 of them have reoffended. And if you see there, the 20 males, 3 reoffended, and those 3 actually had some other additional drug charge connected to them. And then with the females, 3 reoffended with 1 with an additional drug charge. And we are a small enough county and those numbers are small enough. We have anecdotes for every one of those, and we're not trying to make excuses for the reasons that rearrested, but oftentimes it has to do with not having a place to stay, being homeless, and trying to handle some of those other life situations, and it puts them on the wrong side of the law again, and that puts them back in jail. So bottom line is they were rearrested, but the reasons for those rearrests tend not to be the same thing they came in for the first time, which again, although the rearrest occurred, we still felt that we were moving in the right direction for the program. Next slide, please. The worker pod, I mentioned this earlier, 47 males total have been part of the worker pod since we started it in May. And the average age is pretty reflective of the overall average age. It's around 33. And then those that have been part of the pod, of those 45, we've had 38 have been released. And so 18 of those have been time served and they have been out. They have gone to other institutions, whether it's work release or home detention, and 17 have done that. And then of those that have been specifically part of the worker pod, we've had 6 that have been rearrested. And again, there's anecdotes to those, but when we just look at the numbers, 3 of those 6 have been due to non-substance, so coming back for some reason, and the other 3, again, through other circumstances, were connected back to substance use. Unfortunately for us, we had 2 deaths of those men who have been part of our program. And the sad part about it is we really have seen that as a result of a reaction to the COVID-19 and of some of those releases and some of the reasons those inmates were released and where they went to those other institutions. It became a very difficult transition for them. And so what we found is that there wasn't coordination between different entities about what would happen. And unfortunately, both of them were opiate addicted individuals and were within a matter of 24 to 48 hours for one individual being released, and the other one was within a week of being released. Both had overdosed and died. And so that was one of the tragic parts of what we're dealing with, but it shows how strong the addiction is that we're trying to help put away. Next slide, please. This next for us is a demonstration of there is a day-to-day change that we've seen on our campus. And if you see our 2017 critical incidents where someone actually has a write-up for something that happened, whether it was something violent or something that recorded something from the correctional officers, those numbers have declined each year. And part of it has to do with a number of the different programs that we've tried, as well as the JSAT coordinating with those. And so we've been very happy to see this changing because we believe it's helped our COs. It's allowed them to be able to focus on other aspects other than always being the ones who are just trying to have everything locked down and taken care of. It appears that the inmates are starting to see something different. And the term that the sheriff used is to have a little bit of hope. When you have hope, you don't necessarily look for the negative or the way to fight back against the system.
And I'd like to add to that, when you have only 30% of the population attending all these programs and things, and then you have this type of influence in the critical incidents, that's quite amazing. Also helps your insurance, your liability. They love seeing these numbers as well. We report these to our liability people. So they're underwriters and so forth to kind of see what the change is. So I'd say a combination of all these things, both secular, faith-based. A lot of this is taking away the hostility, the outbursts, things like that in our jail. And that's just affecting just a small percentage, less than 50% of our jail population. So.
And our last slide, these are contact information. If you have any questions or any comments for us, we are continually looking for connections. We're continually looking for new solutions that we might be able to find for our staff as well as our inmates in our community.
Dr. Pulver, Sheriff Williamson, thank you so much for a comprehensive overview of your excellent whole person approach program at Jasper County Jail. I welcome the audience to provide questions in the question pane. There have been several that have already been listed, but please do take some time to type in your questions in the 5 minutes that we have left. Bridget O'Connell writes, I am impressed with this program. Congratulations on wonderful work. Are there other rural programs that you're aware of that are being done like this, whether in or outside of Indiana?
Yes, there is. We copied the Garden Project from Stark County. We have, as far as other work programs, we know that other counties do work programs outside the jail. Addiction JSAT program, I'm not really sure about too many that do that. So no, overall our whole concept is we just kind of pick and choose what's we feel that'll be good for us. So.
And the reality is, because we're a small county and our resources are so tight, we don't have the option of going to different agencies necessarily. And so when we started to put this plan together, we realized that we were going to have to trailblaze in a lot of ways for smaller communities and smaller counties. And with the hope that if we could get a couple of these to work in the right direction, that maybe other counties could hop on board or come with other ideas. We have other counties around us that we're in the beginning stages of maybe reaching out to them and starting to combine some of our resources. And so we're very optimistic that there can be new ways that we can work together, especially in rural counties.
That's an excellent point about having to consolidate resources, whereas in larger organizations, or excuse me, rather larger geographies, there might be multiple agencies and multiple stakeholders to support that. In the rural communities, you really need a centralized leadership. As you look at that centralized leadership, Dr. Pulver, Sheriff Williamson, what does the next few years on this program look like? What are areas of improvement and what are other areas of extension programming that you're seeking to offer?
Well, I'll just say one word, transitioning out of the jail. That's a big one with housing. We're already in talks with St. Joseph College for women, and that's going to be a great, because St. Joe's is actually up and running again to provide education, housing, jobs, things of that nature, and we're right in the middle of it. So transition to me, I don't know about Dr. Polk.
I think a lot of it does have to do with our transition. We are continually trying to hone what we're doing with the inmates on the inside and when they're here. I do know that the pretrial release has started to impact some of what we get to do with them or some of what we get to talk to them about for the length of stay they might have. Some of that coordination that we might have had a year ago as far as knowing when someone was walking out, that might be cut down dramatically because of the change in bond that they have access to now, or that we think we have 2 or 3 weeks with them, but they're really out in 2 or 3 days. So we have to become as efficient as possible in trying to get that hook into maybe there's an opportunity for them to come back to us. One of the successful pieces that we feel very proud of is that part where they do get released and they can come back and be part of our treatment program. And that provides them with that familiarity working with individuals in that therapy setting that they've already built a relationship with, not just the therapist, but the other people that are part of that group. And then it also provides hope to those who are in the inside that they see that there's a way to be successful on the out. We would certainly like to grow that more and more. Part of what we found is that individuals who maybe have been part of the system for 10, 15, 20 years, they don't have a lot of repetitions of how to just be an adult and be responsible on the outside. They're used to continually taking a sidestep and wondering if they can get away with it. And that doesn't necessarily help them with the goals that they say they want to achieve in here. And so what we're trying to do is we're trying to take that language and turn it into actions and behaviors that they can follow with later. And then, as we mentioned earlier, transportation is a major undertaking for us in a rural area. We have to find a way to get our released people to jobs and then back to home, and knowing where that home is going to be and finding stability for them. And those are continually those things that we need to take care of. We want them to be safe, we want them to be healthy, we want them to have shelter, and we need to make sure they get from point A to point B safely.
Thank you, Dr. Pulver. Several questions regarding the replication of the program. Is there a budget that you could share on high level the number of resources and support that's needed to make this a viable implementation in other counties?
Well, like say to start with our program, we actually reached out to the county commissioners, and they had some funding available in a fund, about $400,000 for a jail fund for inmates that we were able to tap into. And then to keep this sustained, I mean, you're looking at $100,000 plus a year just to provide the addiction, the quality therapy that we're getting here with the doctor. And so, you know, that's big for the startup. And if you're not tapping into the grants and things like that, you're not going to have the resources, in my opinion, unless you're a larger jurisdiction to fund it. So that's about it for funding.
Sheriff Williamson,
we really did start this on a shoestring. I mean, the sheriff is very progressive in his thinking and very willing to put different ideas forward, but we started this with an idea in kind of trying to step off the cliff, hoping that the invisible bridge was there. And we had some really tight months where we weren't sure what was going to happen. And because both of us are dedicated to this community, we kind of hunkered down and tied ourselves in and said, all right, let's see what we can do. And so people that are tied to the community are going to be much more likely to weather the storm early on if you're not connected to other entities or other agencies that are already built to step in and provide the opportunity to provide the services. And so that would be something I would recommend, is find people who are invested in the community that you're working in, and that every person that you help in your community helps that family. And so you raise the water for the whole community, the whole ship comes up.
And I wanted to mention Jasper Newton Foundation, or the foundation in your jurisdiction, is a big resource. A doctor who's committed to the community, your public officials, commissioners, council. You know, if you can get those people on board, then you have access to resources, and you know, that's kind of how we're doing it.
Wonderful collaboration of stakeholders. I know there are so many more implementation questions from the audience. I highly encourage those that have additional questions on how to implement this model to contact Sheriff Pat Williamson and Dr. Chad Pulver with their contact information listed. I apologize that we are out of time for this last session of day one of the INARMS Symposium. Thank you very much, gentlemen, for joining us today and sharing your excellent whole person approach for reentry programming. Thank you so much.
Thank you.
I have two housekeeping items for the attendees. First off, there are CEUs being offered for the sessions. 1 hour of CEUs is available for each session. At the conclusion of the conference, the Division of Mental Health and Addiction will review the attendance roster for all sessions, and then we'll be making a decision on the CEU certification. And then last but not least, regarding PowerPoints and handouts, each of the sessions had a handout section on the GoToWebinar with the ability to download the PowerPoints and resource handouts. If you were not able to do that for a particular session, all of the materials, including the session videos, will be posted on Overdose Lifeline's website in coming week, and we will send out mass communications when that is available. Thank you, everyone, for joining the 2020 INARMS Symposium, joining the Voices for Recovery, Celebrating Connections. This concludes our day one. Thank you.